So we'll start with the CROWN. The CROWN, obviously, a trial of in patient with advanced stage 4 non-small cell lung cancer with ALK. It's a known trial that we've seen the results a while ago, and this is more of an update out of 5 years. Lorlatinib versus crizotinib. Definitely a newer, more potent ALK inhibitor compared to the old crizotinib that we use. And what everyone is hyped about rightfully is the significant difference and the long-term outcome that we're seeing, the curves, the progression-free survival, and different efficacy outcome significantly showing that this is a more potent and a standard of care option for patient with non-small cell lung cancer with ALK. The question is, and what happened is, we're trying to compare those other ALK inhibitors that we have, especially the newer generation. So right now here in the US, we have alectinib, we have brigatinib, we have lorlatinib. And the question that everyone is asking is, should we use lorlatinib as the first one, appearing with doing peak cross-trial comparison, which we don't like to do, but we all do it, understanding the differences, is that it appears to be more potent and numerically giving us better number than the others. But there are other factors, which is again, if these two are not compared with head-to-head with each other, for instance, alectinib and lorlatinib, brigatinib, then and no OS data, then is it really should be the one? The toxicity profile. The toxicity profile is different. And also how it could affect second line when we know, for instance, lorlatinib could be used in the second line after alectinib. A lot of questions. I think it's an option. It's a standard of care with a trial that has shown an excellent to outstanding result, and we need to discuss it with our patients and give them their option and explain the pros and cons and different toxicity profile and things like that. As for the other exciting study, which is going to be on the plenary session, we're filming this before the plenary session, is the LAURA study, which is giving osimertinib, consolidation osimertinib, EGFR inhibitor that is a standard of care in the stage 4 setting and also in the adjuvant setting after surgery. This is going to be after chemoradiation for locally advanced cancer, and it is definitely going to be a practice changing, and we'll see more of the result coming in the plenary sessions. But again, I think for community oncologists, for any oncology providers, this is going to be probably a new standard of care. So the PALOMA-3, which is basically comparing subcutaneous amivantamab versus IV amivantamab, a little different setting. It was with the lazertinib, which is not necessarily here what's available in the US. But the concept is to compare something we've seen either with other cancer drugs, especially in the heme malignancies, was initially it was IV and then transitioned to subQ. I mean, I think doing subcutaneous injection is definitely much easier for the patients, definitely for the oncology providers, for the institutions, but again, repeating myself, is for the patients. Comparing to go with a much longer infusion that requires several hours, especially at the beginning, the first few infusion, with a quick subQ injection. I think that's going to be definitely make a big difference, especially as we know, most importantly, that the adverse event appear to be in this trial in comparison, significantly less. Whether the reaction, which is something we see a lot, or also the VTE, venous thromboembolism. And also the data did show, that the potentially there might be some more efficacy on certain, endpoints. We don't know exactly, why, what's the biological reason, behind that. But all this, I think, make it potentially a practice changing again from supporting our patient needs, from supporting also the institution where it'll be easier to give this drug subQ.